our 20th in a total number and the 10th tumor board, specifically in malignant hematology and bone marrow transplant. I wanted to thank all our attendees as well as our panelists, both from the United States as well as from Egypt. We have a few cases today that we will go over, and Dr. Noha Isa will be our first presenter, and we'll have a nice discussion after we finish this first case.
Okay, Assalamu alaikum. Good evening, everybody. Good evening, my professors and my colleague. My name is Noha Isa. I am Associate Professor of Clinical Hematology in Mansoura University. Today, we're going to present this case. She is 84 years old, Saudi female. She presented to us in October 2022. She known to have hypothyroidism, and otherwise she is medically free, no other chronic illness. She was in her usual health state till 2 months ago before this presentation, when she started to complain of unusual fatigue with progressive course, which exacerbated by physical activity, associated with weight loss about 15 kilograms, with decreased appetite, as well as she has also shortness of breath. The patient denied any swelling or any other symptoms. As regards the systemic review was unremarkable. Past medical history, she got herpes zoster 2 years ago, otherwise irrelevant. She has negative family history. She is on thyroxine and gabapentin for post-herpetic neuralgia. The patient has a history of contact with animals, and she received 2 doses of COVID vaccine. Upon examination, she was comfortable lying down in bed, conscious, oriented, stable, looks pale, ECG status 1, underweight, mouth gum showing gum hypertrophy. Mouth examination showed gum hypertrophy. Also on examination noted there is bilateral cervical lymph node significantly enlarged, about 2 by 3 centimeter. Also bilateral axial lymph node significantly enlarged, 5 by 6 centimeter. By asking the patient, she said it is since 3 years back, not harmful for her. She didn't give attention for that, and she didn't seek medical advice. Other systems were remarkable. This patient referred to us as a case of acute leukemia. So from the history and physical examination, we can set some differential diagnosis. Maybe this is a case of acute leukemia. Could be explained by the acute symptoms and the mouth examination showing gum hypertrophy, pallor. But why this lymph node since 3 years? The presence of this lymphadenopathy since 3 years asymptomatic could give attention to lymphoproliferative disease with progression or with Richter transformation at present time. But why this gum hypertrophy? Is there is local cause for gum hypertrophy, or there is association, or what? So it could be an acute leukemia or acute onset, and this is lymphadenopathy for all the infection. Maybe, yani this is my differential diagnosis from history and physical examination. We can set this differential diagnosis. So we from laboratory data, the patient has CBC on presentation 5.1, hemoglobin, platelet 25, white blood cell 18.5, macrocytic 119 MCV with reticulocytopenia. The biochemistry all within normal, except uric acid mildly elevated. Liver function test within upper limit of normal, B12 elevated, and folic acid within normal. The peripheral blood smear showed marked lymphocytosis with 5% blastoid looking cell with abnormal looking lymphocyte with mature features. So there is blastoid looking cells and abnormal looking lymphocyte with mature features. This mature feature could explain all the lymphadenopathy. Let's see. The patient did peripheral blood smear, flow cytometry on peripheral blood smear, which showed 2 population, 18% myeloblast and 70% lymphocyte. This lymphocyte are positive for 45, 19. They did a great panel. CD45, CD19, CD5 DIM, CD23, CD200, CD20, and CD79 kappa light chain restriction. And negative for other marker like FMC7, CD4, CD3, 56, 38, 33, and CD117, 10, 3, TDT, MBO, lump. The myeloblast showing expression 45, 38, 33, 34, 117. Other marker B cell and cell were negative. So this flow cytometry concluded that in the peripheral blood there is 2 discrete abnormal cells, and they counted more than 20% of blast in the peripheral blood in this blood film. They concluded that there is 2 population of normal cells could explain simultaneous existence of AML with chronic lymphocytic leukemia. So for this patient, we proceeded for bone marrow aspirate and biopsy. We sent out lab through Bioscientia to Germany, which showed bone marrow, hyperserum marrow, severely depressed erythropoiesis, severely depressed granular piece with bone marrow diffusely infiltrated with 2 population of cells. Mononuclear cells with large nuclear to cytoplasmic ratio, scanty cytoplasm, most likely blast seen in both interstitial and patchy infiltrate with background diffuse infiltration of mature looking lymphocyte. Severely also depressed megakaryocyte. This picture shows the black arrow showing the blast and the red one showing the mature lymphocyte. Also picture P, the black one showing the blast cell and the red one showing the mature lymphocyte. This is also bone marrow biopsy. This is low power showing with this red arrow the infiltrate. This one showing by high power. The clinical pathologist, she wanted to attend with us today, but she has social issues, so she can't attend, unfortunately. The red arrow showing infiltration with the blast cell and the green one showing the mature lymphoid cell in the bone marrow biopsy. So as well, the aspirate and biopsy confirmed there is 2 different population by morphology. Even blast about 60%, and it is medium size and differentiated. Lymphocyte, the new issue that the lymphocyte 35% with venous cytoplasmic age. So this is the flow cytometry again for the bone marrow. The previous one was for the peripheral blood. Blood cells are positive for CD4, CD14, CD33, CD11, CD16, CD21, and 117, almost similar to the peripheral blood. And the negative for other markers, including lymphoid, myeloid, monocytic, lymphoid, and megakaryocytic markers, mature myeloid fluid. Also, this flow cytometry show with 37.6 of all analyzed cells are mature monoclonal B lymphocyte with immunophenotyping showing CD19 positive, 20, 22, 23, and 38, and 43, 79, and also 200 are ROR1 and kappa positive, which some sort of different from the peripheral blood. CD5 in the bone marrow is negative. In the peripheral blood, it was dim. In the flow cytometry in the peripheral blood, they concluded that it is simultaneous existence of AML or CLL. But from this flow cytometry, we can't say it is CLL, frankly. Here, CD5 negative, CD23, it is positive. ROR1, yes, it is marker for CLL, but it is not specific for CLL. It is also positive, could be positive for other lymphoid marker. It is mostly with minimal residual disease in CLL. CD200, it is, yes, it can differentiate CLL from mantle cell, but it is not also specific. It can be seen in other lymphoid cells. From this bone marrow aspirate and the flow cytometry, it is concluded that this is acute myeloid leukemia, not otherwise specified, with morphology and immunophenotyping showing monoclonal B lymphocyte. The IPT stated above is atypical for CLL, mantle cell, follicular, or hairy cell leukemia. And this morphology, which showing 35 villus lymphocyte, possibly consistent with marginal zone lymphoma, is still cytogenetic awaited. So what do you think? Yani, you agree it is acute myeloid leukemia with flu site with this find could be CLL or LBD, not otherwise. No subtype could be reached. Is there further workup we can do for this patient, or it is sufficient for diagnosis?
Dr. Alkawaz, and if you don't mind, Dr. Anuha, if we can circle back to the pathology, the bone marrow. Here. Dr. Alkawaz, any comments from your side for looking at both populations and your interpretation based on, I know, the reports?
Sure. So let's address them separately because they're obviously two separate diseases. Likely the CLL has been, well, the chronic leukemia has been going on for a long time, and this acute leukemia is sort of an acute onset. As far as the chronic lymphoid leukemia, the difference in phenotype is a little unusual, but it also can be explained if the blood and the bone marrow were run by two different labs. Notice that they clearly say that the CD5 is dim. So depending on the strength of the fluorochrome that is used in lab number 1 and lab number 2, the 5 may be negative in one and slightly positive. Where they run the two flows on the blood and the bone marrow, were they performed by the same lab?
No, not the same lab.
Exactly. So that can explain
the second
it.
one, second one, Tomorrow, Germany, through by Sinche. The other
So
one here
that explains why there's some difference. It also could be somewhat subjective. Sometimes it's less subjective than morphology, but yes, even flow can be subjective. FISH should be somewhat helpful in narrowing down the differential. In a case like this, I would have actually utilized immunohistochemistry a little more. I couldn't see whether immunohistochemistry was done or not on the core biopsy. I would have definitely, it looks like it's 34 negative, but 117 is positive. So that's something that I would have looked at and used the percentage for the 117 cells as a percentage of leukemic cells, because that's the most reliable. That's because sometimes the marrow is fibrotic. And so what you get on the aspirate or the bone marrow flow can be hemodiluted. In the phenotype itself, which is 117 for the acute leukemia, which is 117 positive and DR negative, that one can be seen in APL. However, more likely this is it could also be seen in AML with monocytic differentiation. I've seen that a lot with NPM1 mutated AMLs, so that may be this one. But definitely, as far as additional workup goes, for the questionable CLL, atypical CLL, if you want to call it, or just chronic lymphoid leukemia, I would do a CLL FISH panel, which includes 1114. I would have done immunohistochemistry for cyclin D1 and SOX11 and LEF1 on the bone marrow. LEF1 is a marker that is seen more frequently in CLL than other chronic lymphoid diseases. That's for the lymphoid diseases. For the leukemia, I would do immunohistochemistry for 117. I would definitely do a FISH quickly to rule out APL. I would look at the aspirate too, which I'm sure they looked at it. That's why I don't think this is APL, but the aspirate would show certain morphologies that are associated with APL. And last but not least, it's recommended now that we run a next generation myeloid next generation panel. I would also do a karyotype.
Okay, and for immunohistochemistry, it is done already on bone marrow biopsy. Sorry for not sharing this. CD34 and 117 positive expression on large atypical blood cell, DDT negative expression, cyclin D1 negative expression, 20 positive expression on both small and large atypical component, CD5 23 positive expression mainly on a small atypical cell, CD3 few scattered positive, non-contributory. This is the immune histochemistry done on bone marrow biopsy.
Okay, so 5 is positive by IHC. That's, that narrows it down, because, if it's 5 positive on the by IHC, we're back to our differential of mantle and CLL, and that would make it more likely a CLL. Again, having said that, 5 can be on rare occasions expressed in other lymphoid leukemias other than CLL and mantle. So I would have done LF1, but I would also pay attention to the CLL fish panel if that was sent out.
What about the villus lymphocyte? Could be 3 population, for example, CLL and the marginal zone and acute leukemia. What
Morphology, yeah, morphology is, to me, in a case that's this complicated, morphology is a helpful indication, but I think this is a red herring. If there were 3 different diseases, you would more reliably identify them by their flow cytometry. The person looking at those can easily identify 2 different population of lymphocytes. I would not pay too much attention to the villus morphology. It just tells you that this CLL could be some sort of a marginal zone with an atypical DIM5 expression. But if the fish comes back with with an abnormality that's mostly seen in CLL, I'd probably go more with this probably goes more with CLL. The distinction between the 2 I know it may be of interest. I don't know, however, how much this is going to impact the management. I'll leave that to our oncologists.
Yes. Okay. Any comments?
I think, Dr. Nuha, is there any further slides on this case, or do we also talk about the management now?
I want to discuss also if it will be different, TCLL or other lymphoproliferative disorder or not. What about the further, is there added investigation or management we can do, or it is sufficient for diagnosis, final diagnosis?
Mm-hmm. Mm-hmm.
I would vote for CLL more because it's not only CD5, it has also negative CD79A, if I can recall correctly. Can you go back a slide, Noha?
Okay. This one?
No, the flow cytometry done on the peripheral blood.
Okay. This one?
Yes. Okay, so the abnormal B cells were negative for FMC7. There is no 79B in here. It was heterogeneous 20 and 5 positive and 23 and 200. So I think all of these data may recommend or may make it nearer to CLL rather than any other lymphoproliferative disorder.
Agreed. I think that's that point.
But of course, further investigation will not hurt. But I mean, I think it's CLL.
Yeah, I don't think it will help though. I think it would help us understand, but I don't think it. So Dr. Emmons and Dr. Gaballa, would you like to weigh in on the clinical side as well as Dr. Mabed? I see there's quite a bit of the panel is attending today.
Yes, certainly. So there's many points in this case. The first one is that the lymphoid disorder certainly seems to be chronic, be it an atypical mantle versus CLL, given the many years of lymphadenopathy the patient had. In fact, the zoster that she had 2 years ago should have been a clue to immunodeficiency and potential for lymphoproliferation. It sort of surprises me if she had significant zoster that her lymphadenopathy hadn't been detected at that time. I don't know if it had.
Dr. Emmons, I lost the sound. Can you hear us?
Incidence of abnormal B-cell lymphoproliferation. They also, if you look at flow series, have as high as 12%. lymphoid proliferation abnormalities of B cells. So it's a fairly common problem in elderly, especially as you get over age 70 and into age 80. The gum hypertrophy is interesting in this patient in that typically one sees this with monocytic differentiation of acute leukemia, and often when it's present is a clue and a risk for central nervous system infiltration of the blast. So that needs to be a concern. It's interesting that the flow characteristics didn't look particularly monocytic in this case, but I am worried about the gum hypertrophy and the potential for central nervous system involvement given that. So that needs to be borne in mind.
Okay.
The treatment of a patient like this is interesting. Obviously, this is an older woman. Typically in this country, we go to methylase inhibitors and, interestingly, venetoclax, which would be potentially serving two functions in this patient, as the combination of azacitidine or decitabine with venetoclax is often a very effective regimen up front for these patients, even with monocytic differentiation. And of course, venetoclax has a role in the suppression, especially of CLL, but even indolent mantle cell lymphoma. So that combination of therapy may be a very successful way to potentially kill two birds with one stone in this case. I think there doesn't need, from my perspective, to be further workup, with the exception of ruling out central nervous system disease, given the likelihood of monocytic disease or monocytic behavior with the gum hypertrophy. And again, I would vote for azacitidine venetoclax to kill two birds with one stone, although the need to treat the CLL may be lesser if it wasn't really contributing to anything but adenopathy. In other words, the anemia and the thrombocytopenia may be purely related to the leukemia, not the CLL at all, but you're going to treat it with it, and it will probably treat both issues.
Okay. I want to ask Mohammed, is lymph node biopsy beneficial for this patient, or it is not needed? Yeah.
I wouldn't go. So we have acute myeloid leukemia. So she is now run by a bus. So I don't have to worry about the tooth that has to be extracted. I will fix all the accident, the major accident that she has, and then worry about the CLL later. And I fully agree with the management that Dr. Emin said. But Dr. Gaballa and our other panel members, would you like to chime in?
Yeah, I'm so sorry. I joined late, so I missed the presentation. So how old is this patient?
80,
How old? She is 84 years.
84?
Yeah.
84.
Mm.
Okay. Azacitidine venetoclax sounds good to me.
No, still not waiting. Yeah, still waiting.
Yeah.
Cytogenetics.
So the only thing that I would ask is, do you routinely do karyotyping or fish?
Yes,
and
yes, it is done on the sample sent out. Yeah, it is done. Waiting just for results.
Yeah, this is very important.
Next generation sequencing in older patients, you have other targets that you might be able to use, whether it's FLT3 or IDH1 or 2, with therapies. It would be very helpful to know the nature of these mutations, if they are positive or negative.
Sure, yeah.
Are those therapies available in Egypt now, Mo?
I would let, can you chime on this?
IDH, no, not available.
It is, I am working in Saudi Arabia at present time. It is present at more higher center, yeah. Some patients are receiving. For this patient, we started for her venetoclax already. And let's see next slide. I give short summary about her treatment options. Yeah, we said it could be supported. Venetoclax or venetoclax or others, cetrabine combination. We started for her venetoclax, but the issue was which dose we can start. Yeah, and we know CLL is a startup kits, and we should start gradually. If the patient is AML, we can start with higher dose. So this was a question. Yeah, for elderly patient, high risk could be risk for tumor lysis syndrome. So from your point of view, which to start. يعني she has both diseases, CLL and AML. Also, the most important, agree it is AML to hit, but to start with startup kits, 20s and 50s in upgrade, or start with those for AML. What do you think? يعني which is
Dr. Emmons, what's your vote?
Well, are you also giving azacitidine with this, or are you giving just venetoclax single?
But by the committee, we decided only venetoclax because we saw the patient unfit for combination, maybe more toxic for her. So we give her only veneto.
Yeah, that's very unusual. I must say, I don't have experience with singleton venetoclax and AML, but given your concern about potential lysis, the peripheral counts are not particularly high in this patient, of course, but there does seem to be a marrow burden of disease. The uric acid in this patient was borderline high at, I think it was 7.5 you mentioned, so it might go higher. I certainly think if you have the luxury of waiting a couple of weeks and seeing what happens, starting at the lower dose just to make sure you don't encounter lysis would be reasonable. But again, I myself wouldn't recommend singleton venetoclax in a patient like this. We would typically be giving both azacitidine and venetoclax. Again, the AML is the more important issue in this patient. And again, the CLL may not be contributing anything that requires therapy as far as we know right now.
Dr. Gaballa, what's your vote?
Yeah, no, I completely agree.
Your sound is cutting out, Dr. Gaballa. Can't hear you well.
You hear me now? Oh, okay.
Yes, much better.
Yeah, sorry. So yeah, no, I mean, I agree. The AML is the problem here. The CLL is not really, I would not be too concerned about it at this point. The problem is, the venetoclax single agent. I agree. It's probably not going to have so much. I mean, I don't know if there's any data with single agent venetoclax and AML. I don't think so. But the AML is the bigger problem here. So if you want to pick one, I probably would pick azacitidine single agent. But in reality, the prognosis here is not going to be good if she's 84 with AML.
Dr. Mabed, did you want to chime in?
Yes, sir. Actually, I do agree. This patient has had two populations, the AML and CLL. So for sure, the priority should be given to the AML. And then I do agree that the most suitable for her is something like venetoclax. And further, maybe after there is 2 or 3 weeks, we can add the azacitidine in addition to the venetoclax.
Got it. So we have the votes is split. I have to tell you, my vote is going to be not to give venetoclax. My vote will be to give azacitidine. And if you don't feel the patient can get both therapies, azacitidine and venetoclax together, then use the azacitidine. The venetoclax effect for CLL is not what's important right now. You want to give venetoclax with the azacitidine if you could. So if you are concerned, you can do the azacitidine and do the startup kit for CLL, as it's a slower transition to the full dose. But if I'm picking, I'm not picking venetoclax. I'll be picking azacitidine as the front.
Okay, already we discussed with the patient for lymph node biopsy or true cut, but she refused already. We started for her veneto. We started with 100 milligram once daily with GCSF support because she developed severe neutropenia with tumor lysis prophylaxis. Thanks to God, passed smoothly. After 2 weeks, CBC starting to show recovery and no need to transfuse. After 1 month complete CBC recovery, even platelet above 150, hemoglobin 11.3, and tolerating venetoclax 100. We didn't increase venetoclax rapidly already. And then dose increased to 200 milligram with the GCSF support once weekly, because once increasing, she developed more neutropenia. Lastly, the patient is fine, no need to transfuse at present time, asymptomatic since 2 months. So from your opinion, you want to add azacitidine, even with this response. She is responding, clinically even lymph node fading away.
Did you try to evaluate the response after 4 weeks?
We didn't do bone marrow at present time. We just did peripheral blood smear, no abnormal cells, and CBC recovering. We know the aim is palliation, no cure. For such a case, to increase venetoclax to 400 and add azacitidine, or we can keep her like this.
Did her gum hypertrophy resolve?
Yeah, mostly, yeah.
So you got lucky and got a particularly BCL2 sensitive AML. They do exist, but they're rare. So that's a fortunate thing, but she certainly needs another marrow to see what the relative blast percentage is currently. And that will help you make a decision as to whether you're going to add in, as is likely going to be the case, any methylase inhibitor, be it azacitidine or decitabine, along with the venetoclax. It certainly doesn't sound like you have to push the dose of venetoclax very much, given the very good response you've encountered already. But the question of the addition of the methylase inhibitor depends on where you are with the marrow at this point. I'm very impressed that the gum hypertrophy resolved. That's actually a case report you may want to write up, because again, the use of single agent venetoclax for AML is not a well-reported or studied issue.
We also surprised because within shorter time, weeks, CBC showing a recovery. For us, it was also surprising. With Ludo, we kept her 100 for 1 month. Yes.
There is a known spectrum of BCL2 response in vitro in AML blasts. So we know some blasts are quite sensitive to blockage of BCL2, others are not. So you're fortunate in this case that you have shown biologically that the myeloid blasts seem to be more responsive to BCL2 blockade, but that's not the most common result. But that's fortunate for this patient, but the proof will be in the pudding of what the marrow shows.
Yes.
And, there is, as Dr. Emmons mentioned, that there are populations, and if I'm betting today, I might bet that this patient might have an IDH mutation. They are super sensitive to venetoclax, and the effect of venetoclax in those is much better than in others. So it's good news. I agree, a bone marrow biopsy is needed, so you can decide. Remember that there is maintenance approaches. I know it's not well studied in without an intensive induction regimen, but this is an 84-year-old lady, but there is the oral hypomethylators. If the patient achieves remission, that I have patients on now for a couple of years, and they're living a fantastic life in remission with AML.
Okay, so our patient is a rare case. Most of AML with LBD or CLL are therapy related, AML on top of AML. So simultaneous occurrence should not be overlooked as possible cause of lymphocytosis in AML, as it has been reported a reactive polyclonal lymphocytosis may occur in isolated case of AML more commonly, and also in MDS. Lastly, thank you.
Thank you very much, Dr. Noha.
I think there was a question in the chat too of the role of GCSF in AML, which is a somewhat debated issue. I think that generally speaking, we tend to avoid it because there is some in vitro data that certain blasts can actually respond to GCSF. In fact, the flag regimens and the regimens that incorporate GCSF because of potential stimulation of the blast, making them more sensitive to the effects of chemotherapy, were developed on that basis. So generally speaking, it is not as used as it is in diseases like lymphomas and others in which you're causing neutropenia, but I'd be curious what the others' opinions are about that.
Yes, agree. Yes, agree. But because يعني we noticed that venetoclax, most of the cases, they are inducing severe neutropenia, and even patient infection, maybe I mean disease-related or immunosuppression. But we adding sometimes we AML GCSF. It could help, yeah.
Yeah, I don't typically use GCSF until we are in remission. Once we are in remission and I have evidence, then we can use it to avoid what Dr. Emmons mentioned.
Okay, for this patient, Dr. Mohammed, she is 84 years old. We trying to palliate as possible. Yeah, and you know, she is fragile patient, not like adult. Yeah, I agree. If adult, we will not add. They are fragile. يعني, so much fragile.
It's you know, I can't argue it was successful. The patient counts gotten better. We just need to know how good is the response in the bone marrow.
Yes.
The peripheral blood is telling us otherwise. It's telling us that things are going well so far. Any of the panel members would like to comment before we move on to the next case? Any other comments? All right. Well, sounds good. Thank you so much, Dr. Noha. Appreciate it.
Thank
Wonderful.
you. Thank you. Thank you. Okay.
All right. Our next presenter today will be Dr. Neda.
Yeah.
Yeah. Hi. Can you hear me?
Yes. Yes, we can.
Thank you. Okay, I think screen is shared well, I think.
Yes, we can see it. Go ahead.
Thank you. Our next case is a very interesting case. She's a young female, 31 years old female patient, presented to our new cases clinic with history of abdominal pain and bleeding by rectum. As regard the history taken from the patient, she had pre-medical history. As regard her post-surgical history, included 2 cesarean sections, sleeve gastrectomy, hernioplasty, and appendectomy, with free family history, no history of any malignancies in her family. The patient went for routine investigations and examination. By examination, nothing was important in the examination except for the site of perioplasty that was significant, but no peripheral lymphadenopathy was seen. Nothing wrong was defined in the patient. However, as regards the investigations, CTC, liver function test, renal function test, all the routine lab was normal. The patient was referred with a pelvic abdominal ultrasound that showed a large well-defined rounded soft tissue region extending to the right hypochondrial region about 8.5 by 7.5 by 12 centimeters with internal echogenic band that was a characteristic target sign for intussusception. And also there was a small localized collection at the gallbladder fossa, measuring 4.5 by 2.8 centimeters. The patient performed a colonoscopy and there was a fecal mass measuring 8 centimeters from which biopsy was taken. As regard the pathological examination of the biopsy, it showed infiltration with atypical lymphocytes of large rounded cells and reticular pattern. The immunohistochemistry that was performed is shown here on the slide. And the final diagnosis was made as a case of diffuse large B-cell lymphoma, despite CD20 being CD20 negative. This was a matter for us. It's rare to find the case of diffuse large B-cell lymphoma with CD20 negative. It was heavily discussed, and we found some or few cases in the literature that was reported cases of lymphoma with CD29. We started the staging process for the patient. PAN-CT was done, also with the bone marrow workup. The PAN-CT just showed the soft tissue mass that was here, or that's there in the cecum, about 15 centimeter, with surrounding suspicious malignant lymph nodes. The bone marrow was free, non-cellular, with no infiltration. At this point, we were at a very suspicious situation that we are suspecting our pathology, that CD20 negative case of lymphoma, and we have a patient with no B symptoms, just fecal mass. We started hyper-sedate protocol for the patient as a case of aggressive non-Hodgkin lymphoma. However, during this period, we were revising the pathology again to exclude first the possibility of carcinoma and neuroendocrine tumors, and to exclude the possibility of Burkitt's lymphoma. As here you can see, the KI67 was about 90% of the tumor cells, although the star appearance was not described in our microscopic examination. The patient started hyper-sedate protocol. During this period, what?
No, I was going to have Dr. Okwas weigh in, but I guess you have more pathology to share before.
Yes, we have more pathology to share before. The fecal mass also was revised again. It was about the third time to be revised. The immunohistochemistry was repeated. Another immunohistochemistry was added, like the synaptophysin, acromogranine, CD56 was also found to be negative. CD20 was negative, and diagnosis of mantle cell lymphoma plastoid variant was made in this case. At this point, the patient already started 2 courses of hyper-sedate, and we had the first cycle, part A, and the second cycle, part B of hyper-sedate. Although hyper-sedate is not the first line in treatment of mantle cell plastoid variant, it's written in other regimens in the NCCN guidelines. So we decided to continue the treatment as the patient was giving a very good clinical response. After the third cycle, re-evaluation was done, and it showed total resolution of the previously noted fecal mass. The patient was clinically improving. She was doing amazingly, actually. We continued the hyper-sedate protocol, and the PET-CT after the 5th cycle showed the metabolically active irregular wall thickening of the ascending colon. The SUV max was about 6, and multiple metabolically active bone marrow areas affecting the axial and the appendicular skeleton, more at the D11, the dorsal 11 vertebra. The SUV max was about 4.6. After this PET-CT evaluation, first of all, the CPC was normal during all this period, just the neutropenia after the cycles. However, the patient unfortunately presented with internal obstruction on December 19th. The patient was admitted at our surgical oncology ward. Laparotomy was done, and right hemicolectomy also was done. Again, another pathology was done on the right hemicolectomy, and it also showed that a case of mantle cell lymphoma plastoid variant. During this period of recovery from the surgery,
excuse me, Nada, it was diagnosed as mantle cell based on cyclin D1?
Cyclin D1, BAX5, and SOX11. SOX11 was focal weak positive.
Yeah, this is only focal. Yeah, okay.
Focal weak positivity.
Okay.
On 10th of January, the patient, during the recovery from surgery, The patient unfortunately developed leukocytosis with absolute lymphocytosis. Bone marrow workup was done for the case. Actually, we suspected bone marrow infiltration by mantle cell lymphoma. However, we encountered an unfortunate surprise. The bone marrow aspect showed 85% blast cell, and the flow cytometry showed that the patient had AML M12.
May I jump in here, Nada?
Okay, jump in.
I will share my screen, yeah, just to show the morphology of the bone marrow aspirate and the flow cytometry results.
Okay.
Okay, so how to share my screen? Let me see.
In the bottom of the screen, you will see share screen.
Yeah.
نعملي on share الأول يا ندى.
ثانية واحدة. هي already loaded.
Yeah, you should decline.
Okay, stop sharing my screen.
Mm-hmm. So, okay, so can you see my screen right now?
Yes.
Okay. Yes. So this was the morphology of bone marrow aspirate received at this day.
We can't hear you well, Dr. Daria.
I think we lost.
Yeah. Is it okay? Can you hear me now?
Yes,
Yes,
but
we can
we
hear
lost
you.
the screen.
Okay. You lost the screen? Oh,
Yeah, can you share the screen again, please?
sure.
Can I jump in?
Is it on now?
Yes.
Yeah, okay. So as you can see, the bone marrow was totally infiltrated by large blasts with increased cytoplasmic nuclear ratio, maybe with very few residual normal bone marrow elements. And this was diagnosed as acute leukemia for flow cytometry, or maybe it's very blastoid form of lymphoma. So this was a flow cytometry. And we found that approximately 75% of bone marrow was replaced by abnormal immature cells. Them for 45 with low side scatter. They express MPO, them CD13, spectrum of 33. They are positive for 117, very bright for 34 and DR, but negative for 123. They have moderate to them 38. They were negative for monocytic markers. And of course, negative for T and B cell markers. The very few B cells here were polyclonal, while the malignant clone was negative for 19 and 10. Surprisingly, it was positive for CD20, although it was reported twice CD20 was negative. But it's negative for all T cell marker. And of course, just let me say that the expression of some lymphoid markers, some B lymphoid markers can be seen in AML cases with PAX5 positivity. Nada can correct me. I think there was no available cytogenetic or molecular tests at this time for further assessment, but
No,
Nada
unfortunately, there was no available cytogenetics at this time of the examination for the patient.
Yeah, because it's usually known that, I don't know, my guess, this was originally a chloroma, and this is the second case of chloroma that is positive for PAX5 in our center in few months. And usually it's misinterpreted as lymphoma.
Yes.
Okay, go on, Nada. I can stop sharing.
We have Dr. Roaya, our pathologist. Would you like
Yeah.
to share your slides?
Sounds great.
Can you please unshare, Dr. Daria?
Yeah, I'm trying to. Yeah. Okay. Here you go.
So as Dr. Ruqayya is getting her screen and hopefully joining us.
Hello, everyone. Can you hear me?
Yes,
Yeah,
I can.
Ruqayya,
Hear you.
I'm so sorry. My internet network is unstable. I'm so sorry.
Oh, it's okay. You won't share
I'll share my screen now.
Sure, sure. So just before, as Dr. Ruqayya is about to present, are we saying that the original diagnosis was not mantle cell?
Yes, unfortunately, for the first time after revision of pathology, we discovered that the patient was not a case of mantle cell lymphoma, blastoid variant. It was
Yes.
a scleroma from the start, unfortunately.
Okay, all right. Go ahead, Dr. Ruqayya.
I'm sorry, did we ever have like fish for 1114 translocation or no?
Yeah, we'll probably have to put this together because PAX5 is a very specific lineage marker. So PAX5 with 20 and with 79A, even if you want to call it an acute leukemia, you have to consider a mixed phenotype acute leukemia.
It wasn't 79A positive.
CD20 negative too.
No, CD20 was positive, but CD20 is, I mean, for lineage assignment, we have to see CD19, either strong or dim, with other markers.
I thought the CD20 they said was negative, no?
With flow cytometry, it was positive. I'm not sure about immunohistochemistry.
On the first two pathologies, CD20 was negative and it was revised more than once with our pathology staff. It was negative and it was heavily discussed in our panel, in our medical oncology panel. At the end, we had to give up. It's a case of lymphoma. Sometimes the CD20 negative. It's here in the literature. It's present in the literature. It's present. It's there. So we had to go with the final diagnosis that was given to us as a case of non-Hodgkin lymphoma.
In pathology, we received various types of specimen. I think the first was on July or June as a colonic biopsy. Okay, it was a small colonic biopsy. It was a small colonic biopsy, and the infiltrate show a typical round cell proliferation. And we made a diagnosis of a mantle cell lymphoma blastoid variant upon positivity of cyclin G1 and the focal positivity of PAX5. After that, in January this year, we received the whole colonic specimen. Is my skin is obvious?
Yeah, it's clear.
Okay. The colonic biopsy, we received the colonic biopsy. The colonic biopsy revealed the diffuse infiltration by a typical medium to large cells, medium size to large cell with blastoid morphology. And upon the previous biopsy, the results of previous biopsy, revision of previous biopsy, as the infiltrate was negative for LCA and all B cell markers like C20, CD79E, and CD19. and also for T-cell marker CD5 and CD3. And another neuroendocrine marker is in pathology, it is around cell proliferation. We made an expanded band of IHC marker. And
Dr. Ruaya, we
We
can't
don't hear you, Rukai.
We lost her.
Hmm.
So as Dr. Ruqayya shared back with us, I think this is a big discussion to have from the pathology perspective. Oh, are you back? Okay, go ahead.
yes, I will start first with the bone marrow biopsy. The bone marrow biopsy show 60% cellularity, and there was a diffused interstitial deposits of intermediate to large size cell with blastoid morphology. We made a revision of colonic biopsy and think of acute myeloid leukemia. The first we made NBO. The NBO revealed the diffuse positive immunoreactivity in neoplastic cells. Also, CD34 was also diffuse positive. However, CD117 was negative. And here BAX5 revealed focal and very weak reaction in the tumor cell. In contrast to the biopsy BAX5 was more strong and in larger percent than the excision biopsy. Cyclin D1 revealed weak nuclear reaction in neoplastic cells. The lymph node also on local examination, there was a preserved architecture. However, upon higher examination, it also showed infiltration by the same tumor cells. On bone marrow biopsy, so we diagnose this case as extramedullary myeloid sarcoma or granulocytic sarcoma or as non-coloroma, and it is a rare form of if its presence without bone marrow involvement. For emphasis, the colonic biopsy was 6 months earlier than bone marrow biopsy. Bone marrow biopsy also show diffuse positive reaction of this infiltrate for MPO and CD34, and CD20 was negative, CD117 negative, and the cyclin D1, in contrast to the colonic biopsy, revealed the diffuse strong nuclear reaction in the blast cells. So we report the case in the bone marrow as acute myeloid leukemia with cyclin D1 expression. Upon reviewing the literature, we found 2 papers, one entitled cyclin D1 expression in acute leukemia that was performed in Mansoura University on ALL and AML cases. The cases show expression of cyclin D1, but without no significant clinical impact on the patient. Another paper also shows the expression of different types of cyclins, and also they report expression, but they didn't find any significant relationship between cyclin D1 expression and AML. So the case misinterpreted firstly as it diffuse large B-cell lymphoma or mantle cell lymphoma.
Did we lose you again? Yes, go ahead, Dr. Ruqayya.
Okay. Do you hear me?
Yes,
Yeah.
we can.
Yes, I summarize that the colonic biopsy in the that can
Your voice keeps going out. Okay, I guess the sound is gone. So from, this is an interesting situation here that I'm unsure actually how to look at this. Dr. Al-Kawaz, what's your take on this?
I'm so sorry
It's
for unstable internet. I'm so sorry.
No problem, no problem.
it,
Thank you, Dr. Fayo, for sharing.
Okay.
it's fairly unusual. It sounds like the PAX5 expression was robust in the initial biopsy, but then it became very dim. It's always important when performing stains to establish lineage. And when one of the lineage markers is iffy, we always go for another. The 20 was the 20 should have been a warning sign. The other warning sign that I think they say is that CD45 was negative. CD45 and I mean, I'm not familiar with CD45 being negative in mantle cell. I'm not saying it can't be, but the lack of 20 and 45 just tells me that we're dealing with something immature. That would have triggered a TDT, depending on the PAX5 expression. I don't know if CD79A was performed initially, but it looks like the PAX5 on the bone marrow biopsy was very focal and and it looks like they went back and did an MPO, and that MPO was very strong positive. So with that in mind, that I mean the most likely diagnosis would be an AML here, especially that the PAX5 is sort of iffy, and the 20 is not reliable at all. You can see it in AMLs, that's fine. I don't know if we've looked at other markers like, CD10, CD22, or CD79A, any cytoplasmic B markers. But at this point, what the data that we have suggests in AML, I would have done an 1114 translocation just for peace of mind. But cyclin D1 expression in anything other than lymphoid markers is anybody's guess. It just tells you that the pathway is turned on. Cyclin D1 is positive in a lot of epithelial malignancies. I'm not surprised that it's positive in AML. It's really irrelevant in this scenario. I'm not aware with the SOX11 because they do say that SOX11 was positive. I don't know what the significance of that is.
SOX11 on the biopsy was very focal and weak. Yeah. Upon revision of the slides, we not depend on SOX11 more. As you said, Doctor, negativity for LCA and B cell marker is not a usual thing in cases of mantle cell lymphoma. This case was interpreted at its diagnosis as we did an expanded IHC panel, and the diagnosis of extramedullary myeloid sarcoma was very away from our mind.
Okay, and
as
just
the results of bone marrow biopsy and bone marrow aspirate were negative at this time. They repeated twice.
Actually, yeah, it's correct. So it may begin as only extramedullary chloroma, and then it appear as secondary AML, or I mean, it extended to be AML. And yes, chloroma could present it like that.
Yes, Dr. Dalia, yes.
And just a follow-up for Dr. Al-Kawaz's questions, CD79A, CD22, and TDT were negative in this case, by flow cytometry, I mean.
That's great. So that pretty much...
And also by pathology. And also by pathology.
Okay.
that pretty much excludes an MPAL, definitely with that strong MPO expression. I think our next question would be, what are the genetics for this? And then I'll.
I think PAX5-AML usually associated with translocation 821, but unfortunately we didn't have the
cytogenetics probes
or molecular at this time.
I've seen it in cases rarely in cases other than 821. Yes, 820, but 821
okay.
would also be associated with 19, which we don't see here. So it really is by itself, and when it's very dim, this is AML. The genetics, what I mean is next gen karyotype, etc. It sounds bad regardless.
Let me ask you a question, Dr. Alkawas. Did you ever see this PAX5 positive AML in cases with inversion 16?
I've only seen one case outside 821. 821 is the one that's everybody knows about. I've only seen one case, and the case was a case of MLL rearrangement. It was completely monocytic, and it had dim PAX5. So this comes back to the point that if we're going to base a lineage designation on a single marker, it better be very strong and reliable. And it's probably a good idea to always do 2 just to be on the safe side.
Mm-hmm. Because we have another similar case, but it was associated with inversion 16. So I couldn't find anything in the literature talking about PAX5 expression in AML with inversion 16 cytogenetics. But this would help if you have any data about this.
Yeah, very interesting. So, Dr. Neda, is the case presentation on your side ended, or because
as a case of acute leukemia, the patient started treatment protocol. After the final diagnosis was made, maybe Dr. Dalia will be on my side, that we actually thought a shock for us first when we received the diagnosis as an AML M12. We were facing 2 differential diagnoses. Is it a case of chloroma from the start, or are we looking to a case of secondary AML, or actually maybe it's misinterpreted as the flow cytometry? It was taking some time from us to review all our data again. However, it was unfortunately discovered that it's a case of chloroma from the start. So the patient, as a case of acute leukemia, the patient started salvage chemotherapy. She started flag versus full, and on our side, the case has ended after the flag protocol, waiting for its presence. And as regard the pathology, or as regard the clinical points, we are looking for your opinions about if you recommend any clinical decision to be made differently in this case. I don't know if we have any other opinions in our panelists. I don't know.
Okay, thank you, Nada.
So as a you're going to proceed with the flag?
Yes, we proceeded with the flag.
Already started, right?
Yes, yes.
Okay. But I have a question about the history. She has a history of gastric sleeve or something like that.
Sleeve gastrectomy. The patient was obese, and she has done sleeve gastrectomy as a case of weight reduction.
How much weight?
That was about before starting this case. I think she was about 120 kilograms, and she underwent the sleeve gastrectomy as a method of weight reduction.
Mm-hmm. 120 is before the surgery or after the surgery, or right now?
Before the surgery.
And right now?
She's okay in about the 70s.
Okay, that's good. Okay.
So there's several points to this case. First is with her original diagnosis, which was felt to be a lymphoma, did she have a bone marrow as part of the staging
Yes,
workup?
yes, she had a bone marrow aspirate and biopsy, and both were normocellular and was negative. No abnormal deposits were detected in the bone marrow aspirate or biopsy.
Gotcha. And with regard to her now clear diagnosis of leukemia, do you have any further genetic markers? So do you know whether she's FLT3 positive? Do we have FISH or cytogenetics or molecular genetics on this leukemia?
I think we will wait for the recovery of her bone marrow, and then at the time of reevaluation, maybe if there's any residual blood cells, we will do cytogenetics, because at the time of diagnosis, we weren't having any cytogenetics or molecular probes at our center, unfortunately. Usually we have it, but at the time we didn't have it.
It's concerning because the hyper-CVAD regimen, which has typically been used in ALL, has also been used in biphenotypic leukemia with response. So myeloid blasts do have a tendency to respond, and the fact that she's bounced off an intense regimen like hyper-CVAD suggests that there's resistance, and knowing whether she has a FLT3 ITD mutation or some of the others that Dr. Hijazi had mentioned before, IDH1, IDH2. Again, these would be also unusual in a younger person. This is a young woman, a relatively young woman. We also worry in young women or men with presentations of AML about a potential for familial AML. Is there any suggestion that she's unusual in appearance or anything that might suggest that she could have a familial syndrome leading to her leukemia?
I know her examination was free. She didn't have any abnormality, either physical or by examination. I don't think there is any familial mutation maybe behind this case, and the patient had no family history of malignancies, no hematological malignancies, nor even solid tumor malignancies.
FLT3 wasn't done for this case, Nada? I believe it was done.
What?
FLT3.
FLT3.
Because it's usually available at the oncology center, so I believe it was done, but I'm not sure about the result.
Give me 1 second.
Okay.
And why was the FLAG regimen chosen as the induction regimen for this?
Negative. It was done and negative.
It was negative?
Yes, it was negative.
Okay.
Why was the FLAG regimen chosen as the induction regimen for this patient after failing hyper-CVAD?
I think you prefer to give Dr. Robert.
So that's a good discussion. So what regimen? She got 5 cycles or 6 cycles of hyper-CVAD, is that right?
5
total?
cycles. 5 cycles total, yes.
And no response. What we now believe in hindsight is a primary myeloid sarcoma that progressed on hyper-CVAD to involve the marrow, which is it's rare, but it's not unheard of. It happens almost always. It will go to the bone marrow as long as the disease is uncontrolled. But what do we do now for this patient? And do you have an answer on the question into is that why the salvage was chosen to be FLAG, or did you say CLAG? Is it cladribine or fludarabine that you're?
Fludarabine.
Okay. Is that your standard salvage?
Yeah, pretty much.
We're gonna another tough case, unusual.
Dr. recommend there is any other regimen rather than the flag?
I mean, additional molecular hooks would be important in this younger patient with aggressive leukemia, such as knowing whether there was an IDH1 or IDH2 hook here. Also, other genetics as far as risk. She's already defined herself as somebody who's bouncing off hyper-CVAD. This is somebody who's certainly going to need a transplant with any long-term hope of control of this disease. But the question of how to get her into remission now is a very critical one. And I'm very worried that she's just bounced off hyper-CVAD. That's an aggressive regimen, even with drugs that are, effective against many forms of AML. So this is worrisome.
So what you can do?
Well, that really, again, I would try to get molecular markers, IDH1, IDH2. You have to start thinking outside the box for somebody like this. If she has a very dysplastic genetics in the background, one might be thinking of methylase inhibitors and venetoclax type stuff rather than standard induction regimens. But this is a younger person. We have to be careful. The kinetics are clearly high on this. It was 90% Ki-67, I think, on the original stain. So, I mean, clearly very kinetically active, not like an older person's leukemia that has a relatively high number of mutations, but relatively low cycling intensity. So, the relative use of things like BCL2 blockers and venetoclax, and methylase inhibitors may not be as useful. But again, understanding the molecular biology of this is going to be critical to make good decisions about how to go forward with therapy. And I'm not sure that flag is necessarily going to do it in somebody who is now failed after hyper-CVAD for 5 cycles. That is a clear indication of very resistant disease.
Yeah.
Yeah. How about Dr. Gawalla? Are you still with us? What would be your choice here in this? I know it started as a lymphoma where you get excited, now turned into acute leukemia at the end. So, but what would your thought process be in choosing the next line?
Yeah, so this is a very unusual case. And I mean, if it's so this is like an AML that's refractory to hyper-CVAD. In terms of the salvage regimens, I mean, I honestly don't, there's no one obviously standard of care with these salvage regimens, and it's very variable geographically, even within the same hospital. So there's not going to be one right salvage regimen. However, I'm wondering if this is someone who actually might, since they failed chemotherapy and refractory to it, I wonder about something like, like azacitidine, venetoclax, to try to get a response and then go to an allogeneic transplant. I mean, this would be my suggestion. I don't know what would you do at your center for salvage for these? I mean, so for us, for example, at my previous institution, we used a lot of MEC, and then here we're mostly CLAG, but sometimes AZA venetoclax as well. But since she's already been refractory to chemo, and I'm not sure she's young, so she's probably gonna tolerate flag well, but I'm not sure if she's gonna get a good response. But I would vote for AZA venetoclax.
I honestly, I haven't had this exact situation of giving hyper-CVAD to a patient that turns out to be a myeloid sarcoma. But you might be right, both of you, Dr. Emmons and Dr. Gawalla, you might be right with AZA venetoclax, but my sense would be to go with a salvage dedicated AML regimen before I go to hypomethylators with venetoclax. And I do prefer cladribine rather than fludarabine in salvage. especially in a case like this, there is a regimen where you use cladribine with idarubicin and cytarabine and venetoclax. Like it's a combination of regimen that MD Anderson has published some data on it. And it might be useful in a case like this where you're hitting it from multiple angles. So you're using the salvage and you're using the BCL2 target that this disease is strongly expressing. But do I know, is this what? I don't know if it's going to work or not, but I think that would be my choice with a salvage regimen, a standard AML salvage regimen. Yes, hyper-CVAD should be a good upfront in general, but I wouldn't consider it a standard AML regimen before I go to the hypomethylators. And what's making me say this, because she's only 30 years old, and the plan in my mind would be a TBI-based allogeneic stem cell transplant to cure the disease if she goes into remission from an available donor.
So I think Dr. Nader has to explore our the available drugs because I think it will be very difficult to offer the venetoclax. So she will explore the available medicines and we'll see what we can do.
Yes, okay. Thank you very much for this fruitful discussion.
Is cladribine available in Egypt?
It's
Yeah, it
available,
is
but
available
not
only
very
for
consistently.
Oh, I'm sorry, what is that?
Not very consistently, like the extent sometimes is present for the patient, but the drug itself, it's not consistently present in Egypt, no.
Oh, yeah, I mean, clag would be a very reasonable salvage for AML, and if she goes into remission, you could take her for an allo, exactly as Dr. Hegazi had suggested.
Are IDH1 and IDH2 inhibitors available in Egypt?
No.
Okay, we'll see also what we can do for the patients in view of the available medicines.
These are two wonderful cases. I don't think we'll have the time to discuss a third case. This time we'll postpone the third and maybe have another case and do it for another tumor board in a couple of months, inshallah.
I would just add to the discussion that clag on top of 5 cycles or 6 cycles of hyper-CVAD is a lot of chemotherapy for this young woman ahead of an allo transplant, especially if TBI is considered. Hence, the risk-benefit ratio of doing clag versus trying an azacitidine venetoclax regimen for somebody who's now bounced off hyper-CVAD may be in favor of at least trying it, though I admit that it's not the standard of therapy for a younger person.
Yeah, it's a tough situation. I don't know if there's a right or wrong answer here.
Well, with that interesting conversation and discussion, we will conclude. And I would like to thank everybody very much, especially our presenters and our panels and the attendees for bringing in questions for us to discuss. And we will reconvene in a couple of months, maybe for another hour on a Sunday afternoon. And enjoy the rest of the day. Thank you so much, everyone.
Thank you. See you.
Thank you.
Thank you, Dr. Muhammad.
Thanks, everybody.